So my name is Rami Salami. I'm orthopedic and spine surgeon working in Dubai. I'll be talking about the surgical site infection in spine mainly, and I'll just have a few points in brief to discuss such a subject that most surgeons in different specialty, they just hate it and hate talking about it. Starting with the basic definition of SSI, which is the mere presence of a pathogen, whether bacteria, which is the most common, fungus or virus, that is causing a local or systemic inflammatory response. This is the definition of an infection, but if you add to it that it is at the site that was previously accessed during surgery, then it is a surgical site infection, and we have to deal with it. The types can be categorized according to the depth or the site of the infection, whether it is superficial like cellulitis, which is fortunately the most common one, deeper into the subfacial planes, the muscles, tendons, and the deep fascia, or reaching the bone, discs, implant, facets, and cartilage. Prevalence of the surgical site infection is really troublesome, because in many meta-analyses and review articles, they found a huge variation whenever they target the subject of prevalence, which from all these data, I can summarize that the rate was from 0.1 to 7%. And this wide range has an explanation or multiple explanations. The first is that the prevalence is affected by the site of surgery. For example, in this nice study, they showed the incidence rates in surgical site infections according to the part of the spine being operated on, having the highest in the thoracic spine, then lumbar, and the least in cervical spine. And of course, in posterior approaches, it took the greater share of these infections. Also, what type of surgery you are performing, it does affect the incidence of your infection. If you are talking about a traumatic surgery, it is definitely higher than an elective one. In tumor cases, they have a higher incidence than degenerative spine surgeries, whether cervical, lumbar, or whatever. Deformities took a higher rate than a degenerative or the traumas. And of course, the classic widely open surgeries have a higher rate than the MIS or minimal invasive spine surgeries. Instrumented cases definitely had a higher rate than non-instrumented or decompression only surgeries. Stainless steel took higher rate than titanium. And in this review article, reviewing different papers, the queen of surgical site infections was the neuromuscular scoliosis. In most of those studies, it took the highest rate of surgical site infection. So it's not just a mere number, that it should be also tailored to the associated factors. Such factors start with the patient, who we as surgeons like to blame and put all the problem coming from the patient, definitely. Extremes of age has the highest than the middle-aged men. Malnutrition, which is usually overlooked by surgeons, especially with busy clinics. Anemia, poor nutrition, emaciated patients, there are trouble coming to you. Diabetes, and I'm not talking about just a single blood sugar reading or a fasting blood sugar reading. It's the hemoglobin A1C, where the infection rate skyrockets after the value of 9 or 10, according to the study you're looking at. Morbid obesity. If you have the luxury to postpone the surgery, if you have a morbid obesity, not just a little bit fatty patient, if it is morbid, more than 40, it is always advisable and preferable to refer the patient to nutritionist, to bariatric surgery, do gastric banding or sleeve gastrectomy, come back in 6 months or 1 year if you can tolerate, and then you will definitely have a lower risk of infections. Smoking cessations, but it will take, unfortunately, months, up to 3 months, until the risk starts getting down. Smoking cessation for a couple of days is not alone does not decrease the risk. Alcohol consumption and immunocompromised patients, whether they are on steroids or the way you scrub the 3 times or once, you are doing scrubbing using gloves, and especially double gloves. And those double gloves should be changed constantly. Wherever you are in the slightest doubt that you have a problem, please change your gloves. After you put your towels, you put your lines, cauteries, suction tubes, high-speed burr, change the gloves. Whenever you remove the sticker out of the eyepieces on the surgical microscope, change the gloves. Whenever you change from side to side, right to left, because you are putting the screws or decompression, in the meantime, change your gloves. Gowns also, impermeable, water-resistant gowns have a lower risk. Draping 2 layers showed a lower risk. Using the different solutions, whether is it iodine-based solution versus alcohol-based solutions, is still a debate. But if you are using it properly, it makes a good result. If you're using iodine-based, you should know, you should wait for 30 seconds. You cannot just put it and start your incision. You have to wait until it kicks in. Also, increasing the risk of infection is the different machines and instruments that we are using. If you are using a surgical microscope, it has a lot of hazards causing an infection, starting with the eyepieces. Whenever you adjust them, and also at the bottom of the surgical microscope, your head keeps hitting, or your instruments, your caissons keep hitting the bottom of the microscope. Whenever you are in doubt, just change this device or instrument. And of course, the audience, if you are a brilliant surgeon doing a very nice case that should be recorded for history lessons, the higher the incidence. Whenever it is above 7, the surgical site infection rates starts rocketing up. Blood transfusion, there's multiple studies. This is one of them that was recently published. That confirmed the about almost doubling the rate of surgical site infections in intraoperative or postoperative blood transfusions. Now, how to prevent them? Of course, it's a long topic. Just I want to focus on the patient optimization, which is again overlooked by surgeons. If you have an overweight patient, send him somewhere to reduce his weight before you start touching him. If he has a high hemoglobin A1C, this is a ticking bomb. Try to stay away from it. Malnourished, anemic patients should be corrected, and their condition should be optimized before that. Similar to any comorbid condition, if he has a heart condition or a poor cardiovascular outcome, if he is a candidate for stents or anything that would improve his peripheral tissue perfusion, you will be on the safer side. And all these patient optimization points, they are not valid for trauma or emergency cases. That is one factor why trauma cases has a higher risk of infection compared to the elective ones. And of course, all the intraoperative environment tips and tricks that we previously discussed. 2 more points I would like to highlight about the prevention, which is the use of vancomycin. It was discussed in many papers and conferences, whether yes or no to use vancomycin. Does the benefits outweighs the risks? One study or review, systemic review study showed a significant reduction of the surgical site infection risks using the vancomycin powder. And to look for the side effects of using vancomycin, whether we are talking about seroma or fluid collection, if we are talking about the vancomycin as a medicine side effects, or delayed wound healing, also the pseudoarthrosis, they were all deeply studied using vancomycin immediate postoperative, intraoperatively during the skin closure or during the wound closure. And in all these studies, there was no significant increase risk while using this vancomycin, or in bacterial resistance, or an increased rate of gram-negative infection compared to the common gram-positive infection. So it is safe to say it is safe using vancomycin during wound closure. Where to put the vancomycin? Is it in the deep fascia or the superficial fascia? If you are closer to the deep fascia, you are in a safer position. If a couple of studies I've been through, they attributed closing the deep fascia in a watertight seal before applying the vancomycin, which needs to be elaborated and studied further. And the last question is how much we put in this vancomycin powders. Many of them attributed the use of 1 to 2 grams per 5 centimeter or 2 inches of wound length. Also how to prevent the risk in high-risk patients. If you're anticipating problem, you can use the vac dressing, which decreases the fluid collection. It decreases it improves neovascularization and improves the granulation tissue. It can be used primarily whenever you're closing the wound, or secondarily whenever you have an infection. And the golden rule is always apply vac whenever you have a tightly closed fascia. If you're not sure about it, don't apply it over it. And of course, the general rules of management of any surgical site infection, they apply in all surgeries, GI or orthopedic or neurosurgery, which is debridement, drainage, washing out, remove all non-viable tissue which they call as tumor debridement, remove all suspicious tissues, local antibiotics as vancomycin and vac dressing. The last point I would like to highlight that dealing with spine infections, there are special considerations that you have a dura, that you should stay away from irritating or causing any tears from repeated debridements or dressings or putting in drain. You have a bone graft and the function of osteoinduction that would be disrupted by repeated washing or a continuous irrigation system using iodine-based solution that would affect the osteoblast, or a vac dressing that would suck all these bone grafts. Having an implant, definitely always the question is to keep stability versus improve the or decrease the bacterial colonization is always an issue. The last thing is regarding whether to keep or remove the implant. This nice article, the review article of about 50 other papers summarize the topic is that if you have an early infection, early detected infection within 30 days, then you are in the safe period where the bacterial biofilm has not yet been formed, and you can just treat it conservatively. If it's more than that, then you have to remove the implant and you can reinsert a newer one. So the take-home messages, despite the increased rate of instrumentation in our practice, still it is a low risk complication. Patient optimization is always overlooked, but still very important. Intraoperative environment plays a major role, and the use of vancomycin is safe and effective. Whenever you are in doubt, use vac safely in primarily and in infected cases. And the last but not least, always remember to do no harm as a target of our practice. Thank you.